Welcome to the Diversity and Inclusion on Air podcast. This podcast is a program of the American Association of Veterinary Medical Colleges Diversity Matters Initiative. The podcast explores various issues related to diversity and inclusion in the veterinary profession and provides the AAVMC an opportunity to offer ongoing diversity programming to our member institutions as well as all veterinary professionals. So my name is Dr. Lisa Greenhill, and I am the Chief Diversity Officer here at the AAVMC. And today we are going to talk about language. So as many of you know, AAVMC has had an initiative the last couple of years focused on spectrum of care. And this is yet another effort that's really devoted to ensuring that students and practitioners are confidently able to offer clients the most expansive set of clinical options to find the one that fits right for the client, their pet, and also all of this without judgment, right? Often you might also hear this called maybe contextualized care, particularly abroad. And we recognize that, fear of being judged by veterinary professionals for not being able to access that highest level of care could potentially be a real barrier for accessing care for many pet parents and pet owners. So what about that highest level of care, that gold standard, air quote, for folks that are not watching, but maybe listening? Sure, everyone wants to be able to get the very best possible new age, new way, like the newest MRI machine, all of the bells and whistles. But the reality is that it's not always accessible to everyone, and not just because of cost, but because of location, because of all kinds of things, just not even knowing that it's available to them. But we also know that for practitioners, veterinary professionals, there may be fears about not emphasizing the clinical options that kind of keep that gold standard language front and center, particularly in academic and practice conversations. So like many DEI related issues and concerns, sometimes there's a latent assumption that when we say maybe that's not language we want to use, that gold standard language might be something we want to step away from. Sometimes we kind of hear folks kind of say, then maybe we're lowering standards, particularly when we talk about issues related to diversity to it. It's an unfortunate kind of conglomeration of language, but it is something that people tend to think about. But that's not what this conversation is about at all. What we're actually talking about is making sure that people and the animals that they care for are getting what's best for them and that bond at that particular time. So today's discussion will explore the language around the gold standard. And to do this, I'd like to welcome my three wonderful guests today, Doctors Jodi Boyd, Ryane Englar, and William Gilles. Hello, welcome to the show. Welcome, welcome. All right, as is our custom on the show, I asked my guests to self-introduce, and we're going to start today with Jodi. Tell us a little bit about yourself.
Hey all, I'm Dr. Jodi Boyd. My pronouns are she, her, hers, and my job is with Colorado State University as the surgical skills educator. Despite the fact that I teach surgical skills, deep down in my heart, I identify as a shelter medicine veterinarian, and that's the lens that I bring to our conversation today.
Great. Thank you so much, my wonderful colleague and friend, Ryane. What's up?
Hi there, everybody. Great to be here. I'm Ryane Englar, and I am an associate professor of practice at the University of Arizona College of Veterinary Medicine. I was trained to do companion animal practice, which I did for many years before coming into academic circles. And so my current role has me directing the clinical and professional skills curriculum, co-directing, I should say, with a great team. So we essentially build the preclinical curriculum, trying to get students familiar with language in the consultation room, options, discussing, engaging in dialogue with clients. And so that's the lens through which I come to this. And my pronouns are she, hers as well.
Awesome. Thank you so much. And last but certainly not least, one of my veterinary besties, and also making a triumphant return to the show. This individual was featured on the very, very, very first episode of Diversity and Inclusion on air many moons ago. And I say moons because in that episode, his cat literally moondust was the end of the show. Welcome to the show, William. Tell us about yourself.
Hi, my name's William, he, him pronouns. I currently am the owner and medical director of a for-profit urgent care in Minneapolis. And prior to that, and the reason why I became really invested in access to care, I ran a program at the University of Wisconsin School of Vet Med, working with pet owners experiencing homelessness and housing instability. And we were really using that as an opportunity to bring students out of kind of the ivory tower for a bit and get a little bit of a taste of what sorts of practical problems pet owners were dealing with out in the real world, so to speak. I made the transition to for-profit out of an interest in finding ways that that sector can help with the astronomical issue of access to care. And we still work a lot with students through externships at the clinic here now. So definitely talk a lot about how we engage with clients and how we talk about the care that we're offering can impact a family's ability, interest, or even whether or not they're going to be able to move forward, continuing to engage with the industry based on that experience.
Great, thank you. So let's dig in. Jodi, I'm going to start with you. How would you define gold standard, like this language?
Yeah, I think it sort of historically comes from veterinary medicine doing what it does best and borrowing things that work from human medicine, which borrows things that work from other places. And so, the historical context, at least from what I've dove into and learned about, is gold standard really comes from economics and currency exchange. And looking at gold used to be the fixed price and currency was sort of compared to it. And medicine in the 60s and 70s was like, ooh, that sounds like something we could borrow, and then created this sort of synonymous understanding by the 90s that it meant the best practices that exist. And so I think that is historically sort of where it comes from and how I continued to define it, even though my full bias exposed, I'm not a user of the term gold standard because of some of the challenges I'm sure we'll talk about today.
Yeah, we're going to get back to that. So, William, anything to add on the gold standard piece?
Yeah, I think the one piece I would just like to draw attention to in that is, the gold standard, especially from economics, was not just how things were, measured as kind of the best situation, or sorry, we've got a dog in the back kennel area is making a noise. So not only looking at how that gold standard is defined, but as a really important piece that other metrics were compared to it. And I think that is a piece in veterinary medicine where, maybe some nuances of the phrase that weren't originally intended feel like some of the big conversations we're bumping up against now.
Can you say a little bit more about that?
Yeah, I think it can be difficult to define in a given treatment plan what the gold standard might be. But then we're also, because that phrase is so prevalent, I think it stops us from being able to explore alternatives because we're so worried about how they might compare to that gold standard. So rather than looking at what data might say about outcomes and is one approach to treatment, what percentage more of a successful outcome might we have, rather than looking at things that way, a lot of times we're talking about what is the gold standard and how is this different from the gold standard, or how would we build a treatment plan that is not as good as the gold standard, but good enough, the best we can do with what we have. And so even just using that comparison language, I think sets us up to not explore a lot of really interesting possibilities.
Thanks. So, so Ryane, when you were in practice, is this language that maybe you used, and how do you how do people use this?
Yeah, that's a great question. I would say when I went to vet school, I went to Cornell between 2004 and 2008. In lecture hall, we would hear the term gold standard. peppered throughout. We really didn't focus a lot in those days, to be honest with you, about engaging in dialogue with clients. We talked more, you had the person who was the sage on the stage, and they came in and said, all right, everyone, this is the disease process we're going to talk about, say chronic kidney disease. This is what you're going to do, from the time the patient comes in through diagnosis, through the end. And what I found was that when I was a student and went on my clinical year, and you were the student that went in and took a history from the client, and you came into the back treatment area and talked to the intern or resident or chief and presented the case, they would ask you a lot of questions, right? What are you going to do next? And what's your plan? And what I found was that there was this inherent, at that time, trend towards you better give them that full, what is the quote unquote gold standard, right? If I didn't come back and say, well, I need a CBC, a chemistry, a T4, I need 2 view abdominal RADs or an abdominal ultrasound, there was less focus about clinical reasoning through and more, we got to catch everything in a way as if to miss nothing. And I think that's the way I understood it. That might not have been the context through which they had hoped I would pick it up. But I learned very quickly to excel in clinics meant I had to do it all or felt lesser. And it really wasn't until I was on the community practice service, dealing with my first chronic kidney disease cat, who had been a long time client of that practice, first time with me meeting them. And I remember the cat came in and was just laterally recumbent and just really poorly dehydrated. To make a long story short, I had my whole plan. And the owner, elderly couple, said, no, we're ready. We need to put her to sleep. And I just remember going to the back, talking to the clinicians about it. And they said, you can't give up on her. What are you talking about? We got to do these 3 things. And it was like this dichotomy, this tug of war, because when I listened to the client, I understood the rationale. And I felt this fight to advocate for the client. And yet it was also this feeling of, well, if you do what the client wants, it's lesser. And you could do more, but you're choosing not to. So, which side of the fence are you going to stand on? I felt very torn. And so I try to use that terminology less. I talk about the implications of it in class, but we talk a lot more about contextual factors and what, determines care.
Wow. Wow. That was a really helpful exercise. I haven't been through that, but I'm sure I'll tell my own Barkley story in the midst of this. But so, is there, what's the upside to gold standard language? Is there an upside? Other than, hey, we've identified that according to something, maybe your experience, medical experience, the literature, whatever, this is the thing that is supposed to give you the best outcome, period. I'm it sounds like ultimately that's what the standard refers to. So, and saying the gold standard, certainly people will infer that is the best possible decision, air quote, decision you can make in terms of projected clinical outcome. Is there an upside to that that's useful within the profession, across the profession? For folks that are listening later, facial expressions are suggesting no. They're would anyone like to weigh in?
I think, the short answer is I think we have overused it to the point where it is no longer useful. I think there could be room, and historically there was room to have it as a shorthand to describe just that, which is, this is going to give us the best chance of success and uses kind of the latest and greatest knowledge and technology that we have available. But I think it's, in my experience, it's been applied to so many things that it has become not quite meaningless, because I think it carries a lot of nuance with it, but it is no longer the tool that I think it was intended to be in the first place. I also never use it. I talk pretty vocally against the use of it. So I understand that I come at that with a little bit of similar bias as what has already been described.
So then let's get to the nitty gritty of it. And what's the downside of this language then? Like, Jodi?
Yeah, I think for me, it's almost serendipitous timing that we're talking about this while the Paris Olympics are going on. And we look at, the podiums, and we have our gold, our silver, our bronze, this pride, this excitement, the tears, the happiness, the what we've worked for has been achieved because we got this gold medal. And now we have this moment. And I think that the downside is we can look at those kinds of situations and we recognize that there is a gold, a silver, a bronze, and people who don't make the podium. And I think that for clients, they want to be the gold medal winner for their pets. As a veterinarian, you want to be the gold medal winner for your clients. And if you're not standing on that gold podium or even the silver or the bronze, and you're not making the podium, and there's nothing you can really necessarily do to change that potentially because of either the resources that you have, whether that's financial, economics, accessibility, that's really disheartening. And there's this inherent judgment of, well, if you're not standing on that podium, then really what are you doing, either as a client, as a veterinarian? And that I think is harmful overall.
Oh, such a great analogy. And I'm also thinking about the last Summer Olympics when Simone Biles wasn't able to compete, right? And she stepped out of competing in a lot of events. And it was like, how can you get all the way there and then not do this thing, right? Like, you've gone through all of the trouble, you might as well and so there's this kind of weird expectation and extension of self, right? And it becomes a reflection, a pathologized reflection of what how people see you. So Ryane, I'm reminded, and one of the inspirations for this particular show was a session, a Spectrum of Care session at our conference in here in DC in April, and I found that even in talking about some of these things and trying to figure out how to become more accessible and how do we step away from this language, that there was this practitioner fear, almost like, well, if I don't talk about the gold standard, emphasize the gold standard, then am I at risk of, not operating, I guess, at my full licensure level because I'm not offering everybody. And it was not about the offer, it's really about the options. I don't know if you recall that whole session, and if you kind of like to share some thoughts.
Yeah, that was really something that stood out to me as well, Lisa. And I think there is this inherent muddying the waters and mixing up the gold standard in terms of what it was originally intended to mean and the standard of care, and then practice acts, and what are we required to do by law, and what makes us do the right things legally, but then also feel good about the way that we're practicing medicine. And I think there's this jumble, right? Of we want to do the right thing, but then we also feel in some ways like the universities that raised us are looking over our shoulders saying, we taught you this way, and you better do it this way or else you're lesser, right? And that's where we get, I can't come close to that beautiful Olympic analogy, Jodi. That's just going to stand out with me forever. But, that feeling of gold standard framing care as best versus worst, or better versus lesser, all versus none. And we forget those in-betweens, and then we still label the in-betweens, right? Plan A, plan B, plan C, plan D. And there is that inherent, well, one is not as good, right? We'd love to be that gold. We can't, oh, let's try silver. We can't. And then we run out of these options. And I think in many ways, many of us were kind of raised or reared in the profession at the academic level to have that almost medical monotheistic view, right? There's one way, period, right? It's the highway, period. And if you don't, then you're bad, or you didn't do the right medicine, or you didn't phrase it right to the client, or the client's bad, right? Inherently. And so I think we just bounce around all these ethical feelings of are we in the right? Are we in the wrong? What are we? And we can't name them. We just know we're conflicted. And so we struggle, right?
Yeah.
And I think that was the first time that some awkwardness came out. I think that was a really great time to sit. Teresa, my colleague, always says, gain comfort in sitting in the discomfort.
Yes.
I think that was the first time people started to name, hey, that's why this term makes me uncomfortable. Oh, that's why it gives me that weird gut reaction, and we don't spend enough time talking about that.
Yeah. I've been really surprised in our initiative, just kind of how often this particular term comes up. And I'm always kind of a little baffled because I'm like, but aren't we supposed to be talking about a continuum? Why do we spend so much time talking here? And so there is this kind of fear of, well, if we don't focus here, then are we good veterinarians? Right? Like, are we good veterinarians? And I'm like, well, but if that's where you sit and that's all you offer, no one is ever asking, are you bad veterinarians because all of these other people are not actually don't have their needs met, right? Like, and I mean, and that's not just in veterinary medicine, that's just in general. When we focus like at the top of the pyramid, there's rarefied air, there's not as much going on, like there's not as many people, it's at the top, right? But there's never a question about our collective goodness if we're focused at the top of any particular pyramid, when we know, again, using a pyramid analogy that in Maslow's, that the bottom, the base, if the base isn't there, it all kind of comes tumbling down. And so if we meeting those needs, up and down? Yeah. So thoughts about other challenges, like what is the barrier then for clients? William, like out there currently in practice, what's the big barrier for clients with this particular language?
I mean, I will try to answer that question. I think it has a lot of different nuances to it, and may not have a direct answer, but where I run into it the most is, I think, thinking back to how we put together treatment care options or treatment plan options. So if we approach a problem saying, this is our goal, and that's the gold standard, and if we can't do that, then we figure out what can we take away from this treatment plan. If you start a conversation there, and this is speaking as someone who my clients have a very wide variety of financial backgrounds, but a pretty high percentage are not financially going to be able to afford the gold standard. I think it's a separate question whether or not, even if you can afford it, I don't think that is always the best option for a patient. But if we're just talking, starting at that one plan and then pulling away different pieces to get at our plan B, C, D, E, F, not only are we putting a lot of judgment on our clients, which may impact their ability to follow up with us or other veterinarians in the future. If there's a feeling of judgment and a feeling that we're not just really happy they're there to figure out how we can help their pet feel better, that's going to make it more difficult for their pet to continue to obtain care. But it also, I think, does our medicine a disservice. If our only options are kind of the best case scenario and then compromises, it doesn't give us the chance to put together a care plan from the ground up with a much smaller, number of financial resources or, transportation or what other logistics we're working with. As I'm trying to think of a really good concrete example, and maybe one that is probably one of the more common situations is if you have a client who has a few $100s and we're really working towards that gold standard, it is not infrequent that those finances may be spent on diagnostics, and then maybe a clinician hasn't thought through well, now that we've diagnosed this, what are we going to do for treatment? And then that client is out of finances. And so from a practical sense, by not having that conversation up front and figuring out what's our comprehensive approach here, and just kind of chipping away at that gold standard as much as you're able to, we've now put that pet in a situation where they're not able to get access to the care that they need. If we started from the ground up and know that we only have a couple $100s to work with, maybe our goal shifts. So we might not get a diagnosis, but maybe there's something we can be pretty confident is going to have a high success rate if we do an empirical therapy. There needs to be a conversation. This is where those options come in, right? We're not necessarily promising we're going to definitely know what's going on and definitely fix it just for less money. But we have a pretty good chance of resolving it, and we can put a plan in place for the next steps if that's not going to wind up fixing things. Or maybe our goal, knowing that this is the financial situation we're in, and we know as providers that's not going to get us anywhere that's going to have a successful quality of life for this pet. Maybe that shifts our focus up front to how do we discuss, palliative care and maybe putting together the best end for what might be a really critical pet, without having to, kind of erode what resources that family has left. I think a lot of practitioners are afraid to have those conversations, but that idea of being able to goal set with a family, I think, can be really helpful. I feel like I've gone on a little bit of a tangent, so I'll cut out here and let someone else give a little bit of input as well.
Yeah, happy to hear from either Jodi or Ryane. Anything to add?
I think that I agree with a lot of the things that William is saying in terms of sort of getting into the how do we solve some of this, and sort of looking at fear. And as Ryane said, like sitting in the discomfort, which is actually where the best learning happens, but is so uncomfortable to be in those moments. And really looking at how do we take a step back and look at those goals, not only for the client, but with those factors in mind for the patient and for ourselves, and sort of getting into that contextualized care aspect of things to really tackle it in a different way.
Yeah, yeah. Ryane, did you want to weigh in?
I think Jodi and William did a beautiful job. Absolutely, all of those things. And I especially appreciate that feeling of we often shy away from some of those conversations in the consultation room. And then we get ourselves stuck because now we're down this road and it's hard to backtrack. So having that goal-oriented approach at the very beginning can really set us up for success, set our clients up for success, create that safe, supportive space where a client can say, hey, you know what, this is my struggle. Whether it's a financial struggle of, oh, I only have X amount of money, whether it's a transport, case issue, or, wow, doc, I took off today at work. I only had 1 day to take off in the next 3 months. I can't afford to take off to come back for the recheck, or those sorts of things. And I think that's where we can really use our creative thinking outside the box spark that brings so much of us into this profession of how can we make it that custom fit, right? And that's where the immense diverse learning takes place, and also the strength of, wow, I can feel really good about myself and the patient and the client because we're now a team. Yeah. And we're now finding out what is going to make for most compliance, right? Most adherence. Because if I can partner with the client, they're more likely to comply. And then we're all going to have better satisfaction and hopefully maximize patient outcome.
Yeah. Yeah. And so that gets into that, this language around spectrum of care and contextualized care. And don't worry, I'm also working on a whole show just about language and veterinary medicine. Like there's a couple of different, this is just one chapter of this, but the spectrum, this context, this, all of these types of things, I like this idea of like, hey, we're going to set these goals together rather than I'm going to tell you this is where we need to be, right, to have the desired outcome. And I think that you know, from my perspective and the type of work that I do, I see, you know, this gold standard piece also layering in this power differential as well, right? That can be really challenging in healthcare. And I mean, it's something I know for me, I've been studying for over 20 years just in healthcare in general. And even, you know, my own personal health professionals who, you know, my primary care, like, you know, he was like, "Why you can call me? Hi, I'm Doctor So and So, Doctor Jones," and I was like, "I am Doctor Greenhill." He's like, "Oh, hi, Lisa. I did not tell you to call me Lisa, but if you'd like for me to call you Chuck, like we can do this, right?" But there is this kind of power differential, right, that exists. You know, oftentimes we might think of it in like, you know, white coat syndrome, but it's not just white coat syndrome, which typically is, you know, we talk more about fear, but there's just this power where here is this person who rightfully has done all of this great study, they're practicing, they're a professional, and we're going to them. But then, you know, it is, if we don't do what they think is the best possible thing, then what happens? And so much of that can be influenced by things like unconscious bias, by conscious bias, by assumption, all kinds of assumptions. And so, you know, years ago, I had a dog. His name was Buddha. He was a lovely little fluffy white thing. One weekend, he yelped in pain, and between Friday and Monday, I dropped 10K on emergency, on the vet, you know, the emergency vet, the x-rays. The next thing you know, we were in and we got the MRI for, you know, and that pushed us to about 12K, you know, by the middle of the following week. And the only option that I was given was back surgery for a disc problem. And I was like, oh, how much is that going to be? 7,500. And I was like, okay. And, you know, it was one of those moments where I was like, wow, okay, I can't bear to hear him wince like this. So I guess I should do this. But also, that's going to push us to 19. and, and mama's pocketbook is empty. Like, right? I'm not sure. And he was 10 at the time. And I was like, I don't know. I just, you know, I don't know. Well, good news was, I mean, maybe good news, maybe not. I don't know. But he had a skin infection. So they were like, well, you got to go to dermatology because we can't do surgery until you get the skin infection. And that's when I called a friend who said, hey, let me take a look at those, you know, those scans and the MRI. And it was like a 6 weeks course of prednisone that cost me less than $10 gave me 5 more years of a pain-free dog. And, you know, I still, all these years later, feel some kind of way that like that option wasn't even on the table. Like it was like magic to have a colleague call CVS and get pick up a prescription, right? The hardest thing was keeping him locked down for 6 weeks, right? And so, but as I've learned more about this particular issue and the gold standard, surgery was clearly the standard. I got 5 more years, and he lived a really, really great life. And you know, the back wasn't what took him out. The back was not what took him out at the end. Right. And so I still kind of have big feelings about that now that I know about gold standard and spectrum of care and contextualized care. And I also like, I just, you know, Ryan, you talked about, and William, you all of you have talked about the kind of nuance of this. And I was like, did they think that because I work in veterinary medicine that this was just going to be okay? Did they think, like, I have a lot of questions about the assumptions and biases that came with me walking through the door. But I'll never forget that less than like a $5 prescription gave me 5 more years, right? So I guess my question then is, what is that? I mean, that for me was my perception versus reality of the reality of this language. But I mean, is that is that it? Was my experience what we're talking about? It feels like what we were talking about. William?
Yeah, I mean, yes, I think I'm very glad you got another 5 years. I know a number of families who have been in that situation where the alternative was euthanasia, and they may or may not have lost a pet because they weren't able to go through with that level of care. And I think as you're telling this story, it just reminds me of a lot of I can't even name exactly where I've heard these, ways that you should communicate with clients. And it's always pitched as like to practice the best medicine, which we all, our ears perk up. We want to practice the best medicine. But then what frequently comes after is, well, you offer the gold standard. And if your client says, I can't do that, that's when you start to move on to these other options. So it's not even like, because we call something a gold standard, it excuses us from thinking about these other options until it's not our fault that we had to go there, right? It is now our client or some external factor that has said it's okay to not do everything that you were taught in school by the specialist to do. And that just was something that really jumped out as you were talking through that story, because I can see how those conversations went in my head. And I know, that was not the intent of anyone, but it's just, it's this very bizarre fear, I think on the part of the industry that's really ingrained in a lot of us that we have to actively break out of.
Yeah, it just feels like a weird game of chicken where it's like, okay, well, I hate to say it this way because it sounds very gauche and really awful, but like, how cheap can we go? Like, it's like, okay, you can't do that. Okay, well, okay, you can't do that. Okay. All right, heavy sigh, you can't do that one either, scratch, right? Like, and then it's like, oh, okay, so you can do, 2 baby aspirin and a new can of Purina.
Yeah. I think it's one of the things that we do at our clinic, and it's been really interesting to see how much people love that we do it. And this was a total off the wall thing. From day one, we've asked as part of intake, is there a budget we need to take into consideration when we put together your care plan? And just having that be one of the first things the clinic mentions, whether it's, nope, sky's the limit, I've got insurance, or I've got $50. Not only does it, I feel like, open up that conversation more, but it really helps us as providers to know, yes, we may need to talk about all of the options, because maybe someone could, pull together thousands and would be interested in doing that if specialty level care were what they needed. But we don't have to talk about it through all of like this is what we should be doing for sure. And here's all of the details and like the doses of the medications we'd put them on, go through all of those details. If they're going to come back with like, yep, nope, 50 is what I got. So what can we do for this? It's such a time saver too. I think that's been really interesting as a provider, but I think it does build a lot more trust with clients to be able to just be upfront about it, because money is awful to talk about. So rip the Band-Aid off.
Yeah, I mean, we have this culture where it's like, ooh, we don't talk about money, and yet all we do is sit around and talk about money in the abstract, right? And so the first recommendation, because my next question is, what can and should the profession be doing differently, right? In relation to this language. So there's that first recommendation. Do you have a budget on the form? On the form there, you don't even have to actually ask about it. You can look and jump from there. What other things can and should we be doing? I mean, Ryane, what are you all doing in your courses out there?
Yeah, great question there. I love also the idea of building in the budget, and that's something that we're working with the students on. So I've seen success with that in our simulated client encounters. And then it's nice to see that that translates into real life, William. For us in the classroom, my colleague Teresa Graham-Brett and I built out our own kind of triad Venn diagram of spectrum of care, contextualized care factors. And so for our students, we broke it into 3 circles that overlap. One is client specific care factors, one is patient specific care factors, and one is kind of vet clinic, veterinary team factors. And so just trying to think of cost is in most of the evidence-based literature, the #1 concern, but what else, you know, beyond cost? And so one of the things we've started to build into appointments is what is your capacity to provide care, as a kind of opening the door to talk about any number of things that the client wishes to share. And so some of that is physical capacity, right? The client that maybe has a Labrador retriever and lives 3 flights up and isn't able to lift that dog up and down to get up and down the steps. I had a client that I remember that this was way back, right? You remember all the things that you didn't do well, right? And I remember prescribing, I don't even know what the cat had, but I gave all these pills to the client because I'm a cat person, I'm a cat wrangler, I can pill anything, right? I'm like a Crocodile Dundee person with the cat. And I prescribed all these pills, and then the cat wasn't getting better. And finally, you know, I was so frustrated. And I remember the client saying, and she was so peacefully calm, which I don't know how she managed it. And she said, I have rheumatoid arthritis. I can't open those pill bottles. Like, I can't open anything. I live by myself. Like, I asked a neighbor, they couldn't do it. And it was like something hit me in the head. It was a light bulb moment of like, I never asked any of these things, right? And I started to ask more, like, because maybe they can afford the treatment or they want to do certain things, but they can't. Or who else is in the household who can help? Like, do you have support outside, right? Those sorts of client-specific factors as we get into those chronic conditions, right? What's your emotional capacity like right now to provide continued care, right? Are we in the caregiver burnout phase? And how can we start to ask those questions? Likewise, opening the door to patient-specific factors. You know, maybe the client would like to do everything, whatever everything in quotes is, and maybe has the financial means, but the cat hates coming to the clinic, hates everything, right? After it gets treated in the clinic, it's under the bed for 4 days. And I never thought about that, honestly, until my 18-year-old cat at the time, who I'd been managing for chronic kidney disease, who tolerated everything like an angel for 4 years, one day just said, I'm done, right? And suddenly I was trying to give her, Bailey was her name, and she's no longer with us, but all of the treatments that I for years told my client, oh, it's easy, give these fluids, oh, give this aluminum hydroxide, give, you know, whatever, Tumol-K. And all of a sudden I gave fluids and she hid from me and never came out for 3 days. And I had to drag her out from the bed, right? And at one point you wake up because you're on the other side of the table now in the consult room, and you say, I can't do this. Like, yes, I had the physical capacity to, but she's timed out, she's game over. Like, what's her temperament, right? And so I think having the freedom to offer those capacity like questions and lifestyle, and what does your cat need, what does your dog want, what's their quality, and how is care affecting that quality?
I mean, it's almost like the kind of flip side, and I you know, I think I may have told William this when I lost that dog, or when I made the decision to let that dog go. It was, you know, the veterinarian, actually our veterinarian, had to have that conversation, that difficult conversation with me. It was like, I think quality of life is like, we're right at that place where we're going to have to make some decisions. And you know, reflecting on it years later, a decade later, I'm like, wow, that must have been a really hard conversation. And I was so happy, but also the other veterinarian who didn't have the hard conversation with me about the back issue and all of the options that were available. It was like such a juxtaposition in terms of comfort, right? Like, it was like they had made peace with the fact that this part of our conversation about my animal over our a total span of 15 years, it was easier to talk about letting him go and euthanasia than it was in this 15-year period than it was for me to talk about one of the most painful experiences of our time together, physically and emotionally. And I didn't get those needs met because there weren't options, right? And so, it made me kind of sour a little bit on like, wow, like, in the clutch moment, like this is it. This is all my option. Like his back is gonna fall out. Yeah, yes, I know people don't have his back, but his back is gonna fall out. So, those kinds of things. So Jodi, what about you? What do you think that, we can do differently with respect to this language?
Yeah, I think that this sort of contextualized care that we're talking about and not necessarily naming is huge. And sort of looking at what are your goals? Were your goals to get back to perfect peak performance with, Buddha's back? Was it just that you wanted him to have a good quality of life and be comfortable, and sort of bringing those conversations with not only the veterinary context of things, like we default to being the sort of medical experts, but we also have to recognize that the people are the experts of their lives and that they're also the expert of their pets. And so bringing that expertise to the table and having those discussions is incredibly important and brings in that humanistic and holistic approach that contextualized care has, where we can't just make our clinical decisions outside of the social context that they belong in, like that they happen in. And so we have to bring those things to the table and have those discussions. And I think the other thing that I like to remind myself of is we talk about informed consent all the time, and it's something that's super important in terms of liability and how we practice medicine. But if we don't offer all the options, we're potentially not doing that justice. We're not actually informing that client of all of the things that exist. And it's like, if you go to a restaurant and someone's like, this is the best dish on the menu, and it's like, I hate fish. If that dish is salmon, I'm gonna hate my experience there. And so really offering all of those options is essential to make sure that everyone has the best outcome. And it's not just the best medical outcome that maybe is what we're talking about when we talk about gold standard, but that everyone has that best outcome. And then that leads into the second thing that I would recommend, and that's really saying what we mean when we talk about gold standard. Are we saying that the evidence-based veterinary medicine that is out there best supports this? It's the only thing that we've done research on. It has the most positive outcomes. Are we saying that based on the context of you wanting a definitive diagnosis or getting as close to a diagnosis as possible, then yes, this pathway will get us closest to that. Or if we want to throw our entire arsenal of treatments at this and employ everything we have in our toolbox, then yeah, this is the option. However, let's take into pieces what the patient will allow, what the client can, do with help at home or whatnot, so that we're not offering the little old lady with rheumatoid arthritis all of the things that they can't do in their home that might make the cat better, but won't make the cat better if it doesn't actually get those things into its body. And so really looking at that in a holistic perspective.
It's so important, so important. So now, as we wrap up, here's my last question for each of you. What is one piece of advice that you would give to vet students who are typically learning in environments where the highest level of care is being offered, right? So like certainly with more community practice, with more shelter practice, with more, of these kind of more localized things, students are seeing many more regular cases than maybe they might have seen 10, 15, even 20 years ago. But the reality is they're still seeing the super sexy, like really sick, really, the really sick animals that are coming to teaching hospitals, specialty clinics, those kinds of things. What is one piece of advice related to contextualized care / gold standard language that you would tell a student? So take a moment and come on off of mute.
I can start. How about
Yeah.
that? I would say my advice, my feedback would be to focus on the relationship right? Who is the person or people right in front of you, right? Who's on that other side of the exam room table? Come around, better yet, that exam room table to stand on the side with them, right? Jane Shaw once said, we're transitioning from the sage on the stage arm of medicine to the guide on the side arm of medicine, right? And so who are those individuals that we're caring for, that we're companioning through, that we're working with, partnering with, and ask questions to be curious, right? Ask questions to understand, let them share who they are, right? Assumption making is normal. It's a part of human life. We can't eliminate that, but check our assumptions, right? Check our understanding and give that client the safety and security to feel that they can share, I can't do this, or I want this, or this is my goal. So I think if we can always come back to that relationship, the who, that leads us to the why and the how and the when.
Thanks for that. So, Jodi.
I think for me, I would say always strip it back to the fundamentals and the why. So from the medical perspective of things, and we think about all the things that we can do, why do we do them? What does that thing change for that person, for that pet? And really strip it back to those fundamentals when you're thinking about how you're building your diagnostic plan, how you're building your treatment plan. I remember when I worked in the ER at Cornell, we would have students come back and say, we need to do a baseline CBC Chem UA. And I would say Gesundheit. And they would look at me and I was like, oh, I'm sorry, I thought you sneezed. Those are 3 separate words for 3 separate tests that might have a fundamental reason to do them here, but let's take it back and say, why are we doing those instead of just having this, a baseline is this. The baseline is your history and your physical exam. That is your best diagnostic and your baseline for every pet that you should be focusing on. And then let's build that database from there. So strip it back to the fundamentals, ask the why, ask what does it change? How does it influence this patient? And then the second piece of that is always questioning the dogma. So if it is this, like, we always do this, then ask the why in those situations. And how does that make sense for the client and the patient that's in front of you?
Question the dogma. I like it. William.
Those were 2 really good ones. I think concretely, one thing that I wish I would have done more of when I was a student is when you get like the big stack of referral, paperwork. And when you're reading through it and trying to figure out, how do I make sure I answer the questions my professor is going to have appropriately about this patient? What was missed before? It was always this like trying to figure out what the general practitioner didn't do. And that's, how we're doing, better, more comprehensive medicine. But what I would encourage students to do is read those and actually look through them and recognize that most specialty care at academic institutions is at that very, very top of the pyramid. And the likelihood is that those veterinarians tried different treatment options or different diagnostic workups because the other 95 times they see that in their practice, that gets them the answer, solves the problem. And so there's a wealth of information in those referral records if you can just shift your focus a little bit and look at it as, here is what probably works most of the time in most real world situations. And I wish I had spent so much more time absorbing that when I was in my 4th year.
Oh, that's great advice. And it also gets to 2 points. One, it should foster more trust, right? Because it sounds like the original framing is, what didn't they do? So they have to come to the specialist, right? And so that's creating some real, what I would consider unprofessional space between colleagues, right? It fosters some distrust, within the profession, that's problematic. But also, yeah, it does say, hey, $5 worth of prednisone could fix this. And we tried that first, and here's why we tried that first, right? And so, I think that, there's also this kind of piece, especially when we are talking about referrals and stuff, that really injects an additional level of judgment, right? So you got some judgment of, oh, this person could not take care of this issue, so they sent it over, they referred it, and then if that person then is like, yo, I can't afford this specialist care, it's like, oh, you've wasted my time, right? It becomes this whole thing, very socialized thing around our feelings about access, our feelings about money, our feelings about healthcare. And I think that, you know, the other piece of this that we haven't talked about is a lot of this also, at least from a client perspective, is in addition to everything we've talked about, though, is the experience in human health, right? So, and what those expectations are, right? You just want the very best that you can possibly get, but not everybody's going to be able to get that for any number of reasons: lack of insurance, lack of, you know, good insurance. She says, having paid a really big hospital bill recently, and I'm insured, right? You know, those kinds of things really shape the experience. And so then to bring those experiences to vet med really can be a challenging for a client who, again, just like all of us, just want medical care for their critter, right? We're all supposed to be on the same team. So so really, really great advice. I really would love to thank each of you for taking time out of your very busy schedules. And again, William, I'm sure that there's critters behind you, like screaming their heads off or doing whatever it is that they do in clinics. But I'm really appreciative of each of you taking some time this afternoon to just kind of talk about these issues. And again, stay tuned. We will be having more conversations about language and vet med over the next few months. So stay tuned. To my guests, Ryane, Jodi, and William, thank you again so much for spending this time with me this afternoon. Please be sure to like and subscribe to Diversity and Inclusion on Air on your favorite podcast app. And we will actually be back next week with a new episode, kind of getting back into the swing of things. And I will be joined by my wonderful counterpart at AVMA, Dr. Latanya Craig, Dr. Jen Brandt, and Elizabeth Cavallaro from our staff here at AAVMC. And we're going to talk about systemic change when we are talking about well-being and diversity. So be sure to check out that show. And with that, I will say thank you again to my guest and see you next time.